Hello, I am Kevin Crocker, Division Chief of Quality and Process Improvement for Montgomery County Hospital District, located in Conroe, Texas. We are the sole 911 provider for our county with a population of just over 600,000 people. Our service only provides 911 responses, and we do not routinely provide interfacility transfers. Our county is mostly suburban and rural in nature, and this is our abstract presentation for reducing lights and sirens responses utilizing historical data. The use of lights and sirens is a common practice in 911 ambulance services across the country, despite leading to minimal reduction in response time and very little evidence to support improvement in patient outcomes. Utilization of lights and sirens is also associated with an increase in traffic accidents as compared to driving ambulances non emergency. EMS providers across the country also have a 9.6 per 100,000 fatality rate, which is higher than our law enforcement and firefighter counterparts. A lot of these fatalities are associated with driving. In 2017, the U.S. Department of Transportation set a benchmark for EMS to respond lights and sirens less than 50% of the time to 911 calls. This has been a national push for several years by many national leading EMS physicians. I've heard many of the national physicians take the stance that utilizing lights and sirens should be treated the same as a medical intervention. We do not perform medical interventions that show no benefit to our patients. So why should we use lights and sirens, especially considering the risk to our providers, if there's no proven benefit to that patient's outcome? Due to the lack of clinical benefit and increased provider risk with using lights and sirens, we implemented a quality improvement project to evaluate our performance in this area, with the goal being to reduce lights and sirens responses. We started by looking at our 2019 historical data to evaluate our lights and sirens response rate, which showed we had used lights and sirens a little over 70% of the time when responding to 911 calls. MCHD utilizes an emergency medical dispatch protocol, and responses are then assigned a dispatch determinant, and the determinants are assigned a emergent versus non-emergent response. While the protocol does make recommendations on that response, medical directors have the ability to modify how the agency responds. So when you look at the data that follows, it could vary in your department depending on a lot of different variables, such as protocols, the population you serve, your department's definition of a time-sensitive intervention, just to name a few. So in 2019, 44,373 lights and sirens responses were analyzed based on their dispatch determinants to evaluate which determinants had high percentages of time-sensitive interventions or had significantly abnormal vital signs. Time-sensitive interventions and abnormal vital sign parameters were determined and evaluated by an internal review panel, including our medical directors. Our evaluation criteria to change a response to non-emergency included dispatch determinants of Omega, Alpha, Bravo, and Charlie level responses. Delta and Echo level responses were not evaluated to change and were left at emergency responses. They also had to have a small percentage of time-sensitive emergencies, such as STEMI, trauma, or stroke, a small percentage of time-sensitive interventions, and a small percentage of abnormal vital signs. If the panel agreed, based on the lack of historical interventions or abnormal vital signs, that a determinant did not warrant lights and sirens response, the dispatch response plan for that determinant was modified down to a non-emergency response. The panel changed a total of 191 determinants from a lights and sirens response to a non-emergency response. In early 2021, the response data for 2020 was analyzed and compared to the 2019 data. Of note, MCHD had a significant decrease in call volume in 2020 due to the COVID-19 pandemic, 47,000 in 2020 versus 63,000 in 2019. While the call volumes did decrease secondary to COVID, no other changes secondary to COVID were made to our response plan or how we responded to 911 calls. So we still feel this is an accurate comparison when you look at 2020 versus 2019. So in 2020, MCHD only responded to 52% of our 911 calls utilizing lights and sirens. As shown in this graph here, in 2019, our lights and sirens response rate was 70%. So this represented a nearly 1/5 reduction with a statistically significant p-value of less than 0.001. Obviously, the COVID-19 pandemic had an impact on our organization and the way we were able to operate and track and trend data. One of the things that we could have done better with this project, but were unable to complete secondary to COVID, was developing and measuring objective balancing measures to evaluate the safety of this process improvement change. While we subjectively have not seen any harm caused by this change, we are unable to measure that in 2020, so it is not part of this abstract presentation. In 2021, when we reevaluated our dispatch determinants, we were able to add some quality balancing measures, with quality staff evaluating any potential fallouts from a non emergent response. They were able to track and trend the data for 2020, 2021, and when we meet in 2022, their findings will be utilized to better refine our responses to 911 calls, and we hope to publish that data as well. Another important factor to this change is public expectations. As you all know, the public expects a timely response when they call 911. Our agency has a robust customer service program, and we routinely are in the top 3 nationally in customer service for large size agencies, according to EMS survey team. To our knowledge, we did not receive any complaints related to response time secondary to this change. Overall, we feel that using your own historical data is a safe and effective way to reduce your utilization of lights and sirens responses. I'm not sure there's a one size fits all approach, as each agency has its own practice driven by their medical directors and the community they serve. That is why we feel that developing an internal guideline to identify critical time sensitive interventions within your agency is an effective tool to evaluate and hopefully decrease lights and sirens responses. Thank you very much.